Hello, and welcome to the 27th Degree with Chris and Nancy. Chris is not able to be here tonight. He'll be joining us next week for our show. Our guests today are Pam Bolanero. Hi, Pam. Welcome back. She's the Associate VP of Acute Care Services at Child and Family Services. And with her today is Wendy Botello, the VP of Acute Care Services at Child and Family Services. That's a mouthful, ladies. So here today to speak to us about the mental health services in Fall River, the new mental health services in Fall River. So before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on the YouTube or your favorite podcast platform and by following us on Facebook and Instagram. Also, please remember to leave a review. 5-star reviews are greatly appreciated. So, Pam and Wendy, let's get started. Let's, if you could share a little bit about yourselves.
Sure.
And your background.
Yep. So I'm Pam Bolanero, and I am a licensed social worker. And I've been doing mental health for many, many years. We'll say just 20 plus. And with a big focus on, mental health with some addiction, some family work, child protective work.
Right.
And I joined Child and Family Services now 4+ years ago. I joined them initially as the emergency service program director, and back in October is when my role changed and I received a promotion.
Congratulations.
Thank you. And my role as the director for emergency services was focusing on mobile crisis and also going into hospitals and evaluating individuals that were in need of an evaluation to determine if they were safe to be out in the community or not. So a lot of people call those like psych evals. We call them crisis evals or interventions. So New Bedford Child and Family Services, the mobile crisis there, was focusing on Dartmouth all the way to Hanson, Mass. So we have our main office in New Bedford, which is our call center. And then we have a satellite office also in Plymouth. So that was all up until January. So a lot of the work that we do is, again, really just determining if somebody is safe to be out in the community, assessing, and if they're not, following through with what the next level of care would be for that individual, or connecting them to like outpatient counseling, psychiatry. It is as they call it, crisis, meaning that we see them in the moment. We try to wrap things up as quick as possible to get them connected to the right services that will continue to follow through. And January of this year, we've expanded all the way to Fall River.
That's great news.
So before we get into that, I'll let Wendy introduce herself.
Thank you.
Hi, everyone. I'm Wendy Botello. I'm a licensed mental health counselor. I've been doing this work with Child and Family Services for about 17 years, a little less than Pam. But I started doing outpatient counseling here in Fall River, and I did that for about 10 years. And then for the last 6-7 years, I've been over in New Bedford as the VP of Acute Care Services. I oversee the program that Pam was speaking of, the Emergency Services Program. And also we have 2 CCS units, which are Community Crisis Stabilization Units, where we have 9 beds for youth and 9 beds for adults. We're actually moving and expanding in New Bedford, and we'll have 12 beds each within the next coming months, actually.
Wow, that's fantastic.
Right.
Now, with your expansion into the Fall River area, are there any thoughts to have like a satellite office down in this area too?
We don't have a satellite office. We actually have an office.
Oh.
We have a 24-hour site
Nice.
right on Pleasant Street, 1052 Pleasant Street. It is staffed 24/7.
That's great.
So we have clinicians available at all times to see individuals that are in need throughout the day and night.
So can you start the conversation off a little bit with what the services in the Fall River area were like? And again, congratulations on getting the contract for this area. And now what's going to change? Like what's the impact that someone with mental health issues will feel?
Yeah. So I'll let Wendy take this on because it's a discussion her and I had a few years back when we knew these contracts potentially would come up, and then how it all started with us taking on Fall River.
Sure. So State of Massachusetts developed the Behavioral Health Roadmap, which they launched last year. And part of that was to design community behavioral health centers. Lots of acronyms today, so those are called the CBHCs. I believe there are 26 CBHCs that were awarded throughout the state, and we all went live on January 3rd. We have been awarded the one here in Fall River, also in New Bedford, and also in Plymouth. As Child and Family Services, we have 3 of the CBHCs, which is really, really exciting. Here in Fall River, the CBHC is primarily housed at 160 Osborne Street. That's where our mental health clinic is.
Okay.
And then 1052 Pleasant Street is where our crisis services are. There's 2 locations here in the city. Sometimes we're able to be co-located. In New Bedford, we'll be co-located at one location. But here in Fall River, it worked out that we have the 2 locations. So at the Community Behavioral Health Center, the CBHC, that's where a person could gain access to outpatient counseling. They could walk in for those services. They could get group counseling, family counseling. We can work with individuals to see if they need case management, peer services, really being able to talk to somebody who comes in seeking services and see what the most appropriate service would be for them. If they're experiencing something that's more urgent, right, that's something more of a crisis like,
right,
then that's where they could be triaged through our Pleasant Street location. And for folks who want to seek services, they don't have to worry about which location they go to. If they go to Pleasant Street and really should be at Osborne Street, we'll figure that out. If they go to Osborne Street and really should be at Pleasant Street, we'll figure that out. So there's no wrong door. We'll be able to work with you no matter what.
Could you give those locations, the addresses, one more time if someone didn't catch them the first time around?
Sure, absolutely. So the Crisis Center is at 1052 Pleasant Street, Fall River, and the Community Behavioral Health Center is at 160 Osborne Street.
That's great. Now, if someone is just knowing they need help and they can just walk in, they don't need an appointment or anything like that. That's fantastic.
Yep. They can just walk right in and somebody will assist them. And again, like if they walk into Pleasant Street, but what they really need is to see a clinician that day just to talk to someone, we will arrange it and get them over to Osborne Street so that they can see that person that day.
That's fantastic. So now, are these locations new or have they been in place there? And are you doing something different at the locations than what we had seen last year?
The services itself. So mobile crisis is not new. That's been around forever. But the way that we're actually delivering the services have slightly changed. Prior to January 3rd, the mobile crisis out here was a different team. And that team not only was seeing people out in the community, but also at the hospitals as well, at Charlton Hospital. On January 3rd, us being the new mobile crisis team out here, what's different is, which is not different for us because it's something that we've been working on for a really long time, is really trying to focus on keeping people out of the hospital.
Yes.
That's not new for us. That's a model we've always done and really tried really hard. I always say to people when they hear like, the crisis clinician is going to be, or the mobile crisis clinician is going to see you, like, oh, they're going to send me inpatient. And what they don't realize is the biggest push for us is to try and look at the least restrictive environment for someone to go into first before we even think about inpatient level of care. So by seeing someone out in the community versus the emergency room, because we're going to be the same team, whether we see you in the community or the emergency room, it's still us that comes in, right? Depending especially if you're a mass health product, it would be us that would come in. So what we say to folks is let us come to you in the community because you're most likely going to be able to stabilize in the community and stay there and connect to services. But if you go to the hospital, we all know how long the wait list is.
Yes.
Right? You're in the wait. I mean, I walked through Charlton the other day. It's so packed.
Yeah.
And you're there for a good 6 to 8 hours, right? And then they still have to call us to come in. We still have to come in and do an assessment. And then say you do need to go to that higher level of care. We still have to type up our assessment before we start bed searching. Say you are one of those individuals that needed that higher level of care and we saw you in your home, we're going to walk you through the process, get you over to a safe environment at the hospital, but your evaluation is done. So your length of stay in the hospital has decreased significantly because you don't even have to wait for us. We're already doing all that work that needs to be done to get you into a safe environment. Or if we see you in the community and realistically, all you need is an outpatient counseling appointment. If you're not going to utilize, the same day access, we're going to take care of that referral for you. And, we've been very fortunate to get people connected to services very, very quickly. We've built relationships with a lot of outpatient providers that they prioritize our referrals.
So I don't know if everyone realizes the impact of the words you just spoke. When you're looking at an emergency room might have 50 treatment spaces. And if a third to even a half of those spaces are taken up by mental health patients awaiting assessments or awaiting placement, this is going to be a huge impact, not only to that population, but to someone going in for other medical complaints because those beds aren't tied up. And that's what causes sometimes those long wait times that we see, the 7 hours, the 8 hours, or longer. So that's critical. It's a critical access point, and if we can free those spaces up or have some kind of solution before they even go into the emergency room, that's priceless, really.
Absolutely.
Now, when you were working out of New Bedford, and your program's been in place for how long up in New Bedford?
27 years.
27 years. Now, did you see with, I know you had the co-response program up there, did you see an impact to the emergency room where you were seeing less patients utilizing that?
Yeah, we definitely saw it. So for the co-response, which is separate than our mobile crisis, well, I mean, it's not separate. It's just the way that they see the patient is different, right? Because they're in a cruiser with an officer where the police department is getting called to a mental health call, and that clinician is going with the officer. And once, the officer determines that the environment is safe for our clinician, they take over at that point. And they're able to assess the individual and then see if they're safe to be out in the community. With mobile crisis, we're going out without an officer, right? So we're getting the call and we're triaging it and we're sending a clinician out without an officer. But to go back to the co-response piece in New Bedford, we absolutely saw a difference because what we noticed is that if a uniform individual comes into your home, it's even we see this in the emergency room, right, with security guard when they're dressed in uniform, that a patient that is exhibiting some psychosis, they don't necessarily respond well to uniform. Their guard goes up, they get very defensive. Then you have somebody like me dressed in regular clothes who comes along and says, hey, I'm here to chat with you. Your guard goes down. Yeah. So you're more likely to answer questions and engage.
It's totally different feel.
Yeah. And by doing so, you're able to gather as much information as you need to then make a decision, is this person safe to be in the community? And most of the time they are. And we did notice that we were averaging about 73% of the calls that folks never stepped foot in the emergency room.
So when you say you get the calls in, who's calling you and what number are they using?
Sure. So the number they're using is 508-996-3154.
Okay.
We have 20 plus towns that we cover, and that is the same number for everybody that they can call us at. So who's calling us? Schools are calling us.
Okay.
The hospitals are calling us if somebody goes in there and they need a behavioral health evaluation. Group homes, parents, siblings, the person themselves, right, who might say, I'm struggling with my mental health. I'm struggling with depression. I'm struggling with grief. Here's how I'm feeling. I'm feeling suicidal. I feel like I might hurt myself. They call us, and then we assess, and we decide to go out to their house or have them come to us. We make a decision around what's best for the client.
So when you say you might make a decision for them to come into you, what's the wait time on all this? Like, obviously, if it's urgent, you're treating that problem right then. But suppose someone's just like struggling, they notice they're kind of in a little bit of a downward spiral and they want to come in and see you. They make an appointment. How long are they waiting to actually get in?
There's no appointment.
thing to
So no, there is no
Oh.
appointment. We have a 1 hour response time to see an individual once we get a call. So the way that it works is once we get that call and we gather all the information that we need, that clock ticks and we have an hour to actually respond to that individual. So say you call me from home and you say like, I need to see a clinician. And then 5 minutes later, we get a phone call from the hospital. You have a new patient here. We're going to prioritize you over the emergency room because the person in the emergency room is in a safe environment. The person in the community is not necessarily in a safe environment. So we're going to head out much quicker to you than we are to the hospital. That will always be a priority. So our average time, and I try to tread lightly in saying it because if we don't make it, then it's like, but we do average about 35 to 37 minutes to the community.
Crazy good.
Yep, and the hospital is about more or less the same thing. There are times that we're actually even less than that.
Right.
Sometimes we've averaged about 24 minutes for a while there. But it all depends on the call volume. So the higher the call volume, the higher the response time is. So instead of 25, 30 minutes, it might take 35, 45 minutes for us to head out there. If you come to our office, our staff are right there. So if you come in and you say, I'm here, I need to see someone. I feel like I need an assessment because I'm depressed. We're going to gather all your information. We're going to make sure that you're safe to be there. We're going to, put you in an assessment room and then assign you a clinician to meet with you there. So there's no need for, some folks will call, especially parents, my child needs to be assessed, but they're in school. I don't want to pull them out of school. Can they come in at 4 o'clock? So it's nice to know that because you can set things up for your day knowing what times they're coming, but it's not necessary to do that. So that's 24/7. So you can walk into our mobile crisis at any given time, or you can call it. We prefer, to be honest, I always say to folks, you call us and let us figure out what's best, right? Is it best to go out to the community? Is it best to have you come to our office? We'll walk you through it. But if you don't want to call us, you could just walk right in.
So what happens in the long term? Suppose I see you and I really like you. And in 2 weeks, I kind of want to see you again if I'm struggling. What happens with, follow-up?
So that works a little bit differently, right? Our role at the crisis center is really to do that assessment and then to be able to link you to somebody who can do more of that follow-up, right? Because you might really like me, but I'm not always available. I don't work 24/7 all the time. So what I'd like to be able to do is send you to somebody like our CBHC over at 160 Osborne Street, where you could link up with somebody there and have regular meetings with them. Because the work that we do, the crisis work, really could mean that you're seeing somebody different all the time, right? It is the nature of what we do and being 24/7 and how we have to be as accessible to that many towns. But what we really want is for you to have those follow-up services with somebody, and we'll find them for you. If not at our CBHC, somewhere else.
So a lot of times people need a medication review, or they're nervous about their meds, or the meds are running out and they might not have a primary care physician, and that's causing an issue. Can you talk us through some of those scenarios?
Sure. I'm going to start at a higher level of care, right? So our CCS units, the adult and the youth units that we have in New Bedford, anybody can access those, right? So you might be in a position where it's not the best situation for you to go back home, but you are voluntary, you are help seeking, you do want to get help. Then we could talk about a short-term stay, generally around 4 to 5 days. For adults, youth tend to stay a little bit longer, closer to 2 weeks, where you can come onto unit, be able to see a medication provider, a nurse practitioner, or a psychiatrist, be able to get medication there. We have nursing on staff. We have counselors on staff. We're doing groups every day.
Oh my gosh.
So we have all of those services for you. And that's appropriate for a lot of folks, right? But not everybody. Not everybody wants to, leave their home and go to one of our facilities. So there are so then going down from there's a partial hospitalization, right? It's not ours. It's not run by Child and Family, but there are other partial hospitalizations that we could refer you to where you'd go for the day. So you get to go for the day, you get to engage in med management, therapy, and then go home at night and sleep at home. And that works for a lot of folks as well. right? But maybe you just need a psychiatrist, right? Maybe you have never had one before, or
Right.
maybe it's not working with the one that you have. Then we're working on making referrals for you, right? And again, we can talk about our CBHC, we can talk about other providers. We'd work with finding in your area, because we are treating 20 plus towns, we'd be able to work with finding a psychiatrist for you.
Does Fall River, now that you have the contract for this area, does it pose any like individualistic or like slightly different scenarios than what you've seen like in New Bedford or Plymouth? Is each area kind of a little bit different?
I think no matter where you are, every town, city is very unique to themselves. I mean, if you go to New Bedford and then you go to our Plymouth area, completely night and day.
Right.
And it's not necessarily it's not the folks that you're seeing, but it's the kind of problems that you might be seeing, right? And so in Fall River, I'm not quite sure we have our finger yet on how different it is than New Bedford.
Yeah.
We know it feels slightly different.
Yeah.
I think one of the things that is a benefit to Fall River is that I worked here for almost 8 years. Wendy worked here for years. And the director for the Fall River office also worked in Fall River. So we all are familiar with Fall River. So coming back here, at least knowing which
Probably
streets
felt like
are one
home.
ways and what's are not, and where to go get your salad, right?
Right.
That's not new to us. I think what's new is what providers are still out in the community and which ones are not, and who are the new providers out there, and understanding like who we should be referring to. That's a little bit new for us. We do have the benefit of having, Child and Family has been in Fall River for a long time, so we can utilize them to really guide us on like different services that are out there. And we've been doing a lot of work with the schools as well out here. So that's been a huge help in getting to understand. And we're picking up quickly. It's not like this is taking us a long time. It's not taking us a long time. We're definitely being utilized since we've been here. And then really connecting with the Fall River Police Department as well, right? Understanding what their needs are and how we're going to best help them as well. So it's been a little, the past it's been 4 weeks.
It has been.
Yeah.
Yeah. It's been a busy 4 weeks.
I'm sure.
It is, we're starting to get accustomed to the same, like folks that we would see consistently. Also to really, which school needs what, because every school is so different in how they handle things.
Right.
So that's been unique. And I don't think it's that much different than New Bedford. It's just that we have such a handle on it because we're so used to who calls us and who the referral sources are. And that piece of it is a little bit different.
Now, when you establish programs, like as you embed yourself more into Fall River, I guess you'll see what the needs are and go from there. But do you have anything kind of on the front burners that you're going to be looking for to initiate?
I think one of the biggest things that I have noticed since we've been here is that there is definitely a great need for us in the school systems. Yeah. We definitely have noticed a significant increase in call volume to the schools. And so we've done a lot of work with New Bedford school systems and understanding like when they call us, what the needs are, knowing which schools has the higher volume than the ones that don't. But we did notice that that is a service here, a referral source here that has been very in demand. So what it means is that then when you're starting to look at your staffing and increasing your staffing, you're looking at hours of the day, right? When do you need clinicians more present there at the crisis center versus like maybe you don't need them as much during like 6 to 10 at night, but during that time, 10 a.m. to 4 p.m. is a high call volume. And that's when you want to look at your staffing pattern and say, okay, that's when we need to increase clinicians because we have noticed that there is definitely a need for us in the schools during those hours.
Do you see all ages?
Oh, yeah.
Mm-hmm. Wow. That's a great service, too.
And we did fail to mention you don't need insurance to see us. A lot of, if you are free care, you absolutely you get the same exact services from us, regardless if you have insurance or not.
That's beautiful. So Now, when you're looking at programs to establish, like especially in the school systems, are you doing like training programs too, like, for the guidance counselors or the teachers? Because I know sometimes they must struggle, especially with the increase in the needs.
Yeah. So we've been doing a lot of presentations in regards to the services that we provide, and it's been well received. We've been mindful of where we're doing our presentation, making sure that we spread it out, not just to the school systems, but to the group homes and to the DCF offices, like all those areas where we're trying to be really mindful and explain what we do. And it's also an opportunity to allow people to ask us questions and give us some case scenarios and allow us to explain, how we would handle something. And that's been a real help. So the service itself for the school systems are not different because it is mobile crisis. They're used to the mobile crisis. What they're not used to is a whole different team that's coming out, and we might have a bit of a different approach in how we do things versus another team.
So someone listening to this podcast and trying to learn about what might be best for their child or their parent, can you kind of walk us through some of the most common calls that you get and what your intervention is and what happens, and maybe look at what happens with a school-age child, what happens if someone noticed their parent is like super depressed and they're calling because they're concerned, but maybe the parent isn't so much, so how do you handle that type of situation? And then how do you handle someone in true crisis? So if we could look at those 3 scenarios.
Yeah, so a typical referral from a school will be, the child might have made some statements. It might be some vague suicidal statements, or it might not be vague, right? It might be, I'm feeling suicidal, I am depressed, and they'll call us. And they'll call us and say, we have a referral for you. We have a student that's that's told us that they don't feel safe, and we feel that they need to be evaluated. We'll always connect, obviously, with the guardian to let them know that we're going out. This is what we're doing, because we want their input as well in this. And so that's normally like a typical call for a school, is a child that's just not feeling safe. Then we also get the behavioral calls, right? The kid that's running around the school or jumping off the stairs. And
I know a couple of those.
Yeah, running out of the classroom and not listening. We'll get those calls. Those are a little bit harder to do versus the kid that's feeling suicidal, believe it or not, because especially if it's a 7-year-old that's running around the entire school, because we don't go hands-on. So it's all about how do you engage that child to listen and sit with you and get them to really just focus on you just enough.
And when they're calling you, are they notifying the parents at the same time?
Yep. So we always have them notify the parents or the guardian that we've been called, and then we typically call them to let them know we're on our way out.
Okay.
So a lot of behavioral stuff, a lot of, kids that unfortunately could be like they're biting, they're hurting themselves, and they'll call us. So it's our responsibility to go out there and try and keep that person as safe as possible. And I should have added that when it comes to kid cases, we also have a family partner who will work with the family and try to connect them to resources in the community.
Separate from one of you.
Correct.
Mm-hmm. Okay.
So we might bring our family partner with us so that they can meet with the parent and discuss, okay, what services do you have in the home? And they might be like, I don't have anything. Okay, talk a little bit about what behaviors they're having at home. And if it's similar to what they're having at school, then where should we make a referral to stabilize this child?
So they're kind of like the expert on what resources are available in that given situation.
Mm-hmm. And they have lived experience. So a family partner is somebody who has usually raised their own child with mental health needs and accesses and utilizing these resources.
That makes such a big difference.
Sure does. Mm-hmm.
Yeah. So that's the child. Yes. So then you go into school, you assess, you make the care plan, and that's discussed, and then you follow that plan.
Yeah, so part of the care plan could be, we might want to see this kiddo a couple more days face-to-face.
Right.
We don't have to do an assessment, but we want to do a check-in, right?
Yeah.
So we might check in on them a couple of days in a row. We might have to go see them at the school. We might see them at the home. The parents might say, I'll just bring them to your office. Or we might say, they don't require a face-to-face, but they require a phone check. So we might call them for up to 7 days to see how they're doing. The good thing about that is that we're building a relationship with that person. And if things look different from, tomorrow looks different than yesterday, then we're going to notice what the difference is. Right. And we're going to be able to identify it as quick as possible to try and resolve it as quick as possible.
Nice.
But unfortunately, there's also times when we're getting called out to schools where we just cannot maintain that child at the school. They're just not safe. No matter what we do, we cannot keep them safe. In those cases, we have to look at a higher level of care. And a higher level of care doesn't necessarily mean that they would go right to the hospital. It could also mean that we can have a discussion with the parents and say, you know what, they would benefit from going into our youth crisis stabilization unit. And we might not have a bed today, but they're safe enough to be at home with their, with supervision until we get a bed. Or we might have a bed today, so we're going to go back to the office, type up real quick, and then let you know what time we have an intake for you. So that's another, we look at all different levels, but if it is a child that we just can't seem to regulate, no matter what we do and no matter what the school does, we might consider that level of care at that point.
Right.
Worst case scenario is somebody who's not safe and they cannot maintain safety no matter what you do.
Right.
And then we're looking at inpatient level of care. And at that point, we do have to send them to the hospital. But we do look at all kinds of different things. We try never to really put a kiddo in an inpatient as much as possible. We try different levels of care before we even get there. But
Well, I love how you phrased it before. You're looking for the safest, least restrictive environment for them, which is, a great way to phrase that.
yeah, I mean, we're utilized not just at the schools, but we're also utilized like at the group homes.
Yeah.
The residential settings, they will call us and say, we have a child that's dysregulated. We can't seem to regulate them. We've connected them to the person that they most are bonded with and nothing's happening. And we might have to go out there and see that person out there and try to stabilize them out there. I always say, like, our role is to partner up with the services that, with the schools, the providers, because they're the expert for that child. They know the ins and outs. They know when someone's behavior has changed, and we want to hear what their input is and then allow us to do our job and figure out what's best for that child.
How long does it usually take you to link up, like after that assessment, when you were saying before, Wendy, about linking them up to a resource that they can form that relationship with? Is the timeline long with that? Because you hear these horror stories of like, people are waiting 2 months or 3 months or 4 months to get in somewhere, or trying the online stuff that may or may not work out.
I think historically that has been a problem throughout the state of Massachusetts. We're still new. January 3rd wasn't that long ago.
Right.
But across the state, I think everyone is making some movement. And certainly here in Fall River, we're making some movement. So as Pam said, we're not a new mental health clinic. We were previously at 66 Troy Street for folks who are familiar with us. And we moved over to 160 Osborne Street, which gives us a lot more room and space to be able to do what we do. But we're a walk-in center, right? So as a walk-in center with same-day access, we're able to link folks up much quicker than we were previously. And so because we're looking at different types of scenarios, we're not just putting everybody in with an individual therapist, because that may not be what you need. You might need more case management, or you might need family therapy. And so we're working with folks to identify what they need, and that allows us to work with a little bit of the clog in the system by just not having enough clinicians to do the work. And so we can look at what do you really need and find that person for you. So it's hard to put an exact timeline on it, but folks should not be waiting months. And that should be getting better across the state as we keep moving through this clog.
That's so good to know.
PrimaCare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. PrimaCare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. PrimaCare is large enough to take care of all your medical needs, but small enough to care for you personally. PrimaCare is by your side.
Now, what about the second scenario where maybe I'm concerned about my mom or my dad, who may not realize they have a problem, but everybody else does? How do you handle those situations?
So it depends, right? It depends what you're providing, right? What's the actual concerns for that individual? If it's at the point where we know that they're not safe, we would assess and talk to them and figure out what's going on. If it's just like, mom's depressed, she's not going to the grocery store like she normally, like her behaviors have changed, but it's not escalated to the point that it would be a crisis, we would give them ideas of things to do, but, and we would offer to do an assessment, but we wouldn't push an assessment on someone that wouldn't necessarily need it, right? Just because they're feeling as though their behavior might slightly have changed, but it's not necessarily to the point where it would be a concern.
Right.
It's a concern for the family, right? They might be seeing, and that can mean multiple things, right? With aging, right? Because with aging comes a lot of different things, including dementia and Alzheimer's.
I wouldn't know anything
that.
about that aging process.
So we have to be mindful of that. So we might ask, like, have they seen their primary care doctor? Like, what sorts of things have you seen change? And we always encourage people to try and get their family members to agree to see us. Ideally, we want people, so I want to say this correctly in a way. So we don't need permission to necessarily do a behavioral health assessment if somebody's at risk. But we want you to give us permission, because we find that if you say, yes, I'll do an assessment with you, you're more likely to have a relationship with the clinician that's assessing you. You're more likely to provide additional information because you've given me permission to ask you questions. When you don't give me permission to ask you questions and I have to gather this to determine if you're safe, it makes it a little bit harder, because at that point you've put your wall up where you're like, I don't want to meet with you. I don't want to answer questions because of that fear that you're going to send me to the hospital on a section.
Right.
So we always try really, really hard to get that. Even at the hospital, if we're going to the hospital to see someone who's suicidal, we ask them all the time, like, are you willing to meet with me? And before we even say we're going to meet with you regardless, right? We try never to say that. We try to say, like, hey, I'm here to assess you. Can I sit and talk with you? Yep, sure, no problem. And then we try to get them to consent for us to sit there with them and evaluate them. That's so key because of first of all, it's very strength-based focused,
Right.
but it also allows the individual to have a say,
Right.
and be like an equal partner, if you think about it that way, in the actual assessment.
In what areas do you think there needs to be better utilization of your services? Like, have you pinpointed, because you've been here 4 weeks already, have you pinpointed any areas where you're like, oh, we're really hoping to do an awareness campaign, to let people know that we are available, like you want them to call you?
So one of the populations that we always find the biggest struggle with, that we really want them to call us, is that middle age group.
Yeah.
The folks that, are working and have families but are suffering, and they don't want to say that they're suffering, right? So we know that that's the highest risk population out there for suicide. And we want to be able to have those individuals. That's the individuals.
Is it? That
is.
surprises me.
Ooh.
Like I would have said,
Sorry.
Oh.
I'll share Wendy's.
Okay. So what happens with that? That surprised me. For some reason, I thought it was going to be like the tweens, or I thought it was going to be like the seniors.
So people think that, but
Yeah.
that's actually not the case. It's actually so it fluctuates, right? There are times where you'll see an increase in adolescents that will, the increase in adolescents who have there's an influx of adolescents that unfortunately attempted or have succeeded. And then you'll see an influx of older population doing that. But realistically, that's not the highest population. It really is that middle age group, and tends to be men. Within that middle age group, especially, you'll notice that there's times when we went to a suicide conference where they were talking about, an individual who has worked all their lives,
Right.
and then all of a sudden they're no longer working and they don't know what to do with themselves. And then you will find that there's a huge increase in suicide attempts in that population, and there might be an attempt that you never even knew there was an attempt. Because they might have attempted and they weren't successful, but they never reached out to get help after that. And that to me, that is the most vulnerable group that does not know how to utilize us. And we noticed that COVID really was an eye-opener for us, because we noticed that a lot of those folks were calling us during that time because things changed for them significantly.
Right.
But then now I've noticed a decrease in those calls, where we're not getting as many calls as we were before, in regards to folks saying, like, I'm having anxiety. Then you meet with them and you realize, like, they've had a big change in their life that has taken place. And so it fluctuates, but it definitely increased during COVID. and it's decreased since.
That makes perfect sense when you think about all the stressors that are on someone in their middle age. Like they have kids, they have parents, they have the job, they're trying to wear so many hats and like juggle everything. And men may tend not to ask for
you've
help.
got end of life with their loved ones. You have divorces. You have kids going off to college, or maybe the kids themselves are struggling with mental health and they don't know how to handle it. So there's all different things that come into play, but that is definitely a population that does not utilize the services enough.
When you're looking at the services that you have lined up for Fall River, are you excited about any program that you're going to be implementing soon or within the year or the next year or two, or is that like top secret?
No, it's not top secret.
So I think we'd want to talk a little bit about co-response.
Yeah,
right?
yeah.
So in New Bedford and in Plymouth, we have a co-response program, and we will be doing the same here in Fall River. So we've been in conversation with City Hall and with the police department and being able to line somebody up for that. So it's in play and it will happen. We just have to hire more staff to be able to do it, and we'll be able to have a clinician who is assigned to the police department who will go out on calls. Right, they'll provide mobile crisis intervention as a co-responder. So I think it's about 80% of calls are actually behavioral health calls that the police department receives. 80% of all calls, right, are behavioral health related or mental health related, and so by having a clinician embedded in the police department allows us to be able to meet folks where they're at and be able to de-escalate situations, again, diverting them from the hospital, diverting them from inpatient, and being able to access services, right, in a way that is more strength-based. And it benefits police officers, it benefits the community, it benefits the police officers even when we're not there. They learn things from the clinician. They learn how to access services as well. And
just the approach is so different.
The approach is different.
Oh my gosh. So can you go into a little more detail with that? So you're actually riding with the police officers in the cars when they get the calls?
Yes.
And then they're probably making sure that the situation is safe for you to enter into.
Exactly. Yep, you have it. So we are riding along. We have a clinician who rides along. Different towns will do it a little bit differently, whether they're assigned to one particular car and officer or whether they rotate through. I think for the most part we're rotating. So that way different offices get the experience with us. And so when it's a behavioral health call and they're not otherwise occupied, they will arrive on scene. We make sure that it's safe for a clinician to be able to enter. And then the clinician is able to meet with the person, right, that was calling, or the family member that was calling about their brother or their child or their mother, and be able to do the assessment right there while the officer is there, as opposed to previously, right, where the officer arrives and is trying to figure out what to do with this person, who to call, how to gain access for this person. The clinician is right there with them and able to do that right there. And if it is a heightened issue that requires hospitalization, because sometimes it does, then we're working with getting them over to the hospital right away. But we're showing up there with paper in hand, ready to go. What's our next move? And we already have that happening. So it starts happening a lot quicker. Or it means that they're going to come to one of our units, or we're going to follow up.
Right.
You know what? I see that you're really worried about your mom. Your mom's not ready for help right now, and she's not a risk to herself.
Right.
But I'm going to come back out tomorrow and talk to her again, right?
Oh my
and
gosh.
so, either us or somebody else will go back out, talk to your mom again tomorrow, and see if we can hook her up to some services. See if maybe then, when she's not feeling as off guard because a police officer and a clinician showed up at her door, maybe tomorrow we can get her to access these services and leave you with some information of who to call if in fact she does rise to a different level of crises.
Now, you've probably seen with the established program in New Bedford and Plymouth, you've probably seen the impact that that's had. And even, can you talk a little bit about that, like what you've seen in the community and with the police force?
Yeah, I can tell you that it is extremely well received from the community. I'll give you an example for Plymouth.
Yeah.
We started not even a year ago. The town appreciates it. They know it's working, that they've asked for a second clinician for a second shift. So, and the reason they know it's one of the things that we have noticed a significant change since there's been I shouldn't say we, but the police department have noticed, and we keep track of it, is those hands-on, right? So if an officer's going by themselves and they're dealing with a patient that's not, individual that's really not cooperative, they might jump into putting their hands on to keep things safe.
Right.
Where if the clinician's there, they do their job. They talk to the individual. They get them to engage in the conversation. They get them to not have an officer go hands-on because they're talking back and forth. And majority of the time, if they do require to go to the hospital for a higher level of care, they will go willingly right with the officer, as they say, where your cab ride to the hospital. They'll go right with them in the cruiser off to the hospital. They do a warm handoff to the hospital. But that patient doesn't feel like you're invading their space because they were part of that. They were part of the assessment, what happened with the clinician. They knew exactly the process that was going to happen next. Everything is told them in detail. Like, all right, we're going to give you a ride to the hospital. Here's what's happening. You're going to go inpatient. We're going to have you medically cleared. And majority of the time, it goes really smoothly. So I can tell you that during the time that we were in New Bedford and still are, the data that we had, and this was now, I haven't looked at it since, say, October, they had gone hands-on, I believe, 5 different times in 3 years.
Oh, my gosh.
So that's huge.
That's so huge. It's so huge, especially if you have kids. I mean, it's already a roller coaster when you have kids. But, when my son was growing up, there would have been such a different feel if a big burly cop comes to the door in full uniform with gun. And, it's just to have someone have a soft approach.
Yeah, the officers, they say it best when I go to roll call and I talk with them is they've learned so much about mental health just being in the car with a clinician where they're just talking.
Right.
So, so it's not even like they're sitting in a classroom learning about it. They're just naturally hearing
That's
it.
the best
and they're
way.
picking up things that they've learned how to use de-escalation when they're seeing someone, when the clinician's not there, because they've learned from a clinician. Like, here's why we ask questions a certain way. Here's why we don't raise our voices.
Right.
Because if you do that, especially if someone is psychotic, that is a trigger.
Right.
So you try to keep a certain tone in your voice when you're talking to them. Here's why we approach them with our bodies this way versus going, lunging at someone or invading their space. So there's a lot of that conversation that happens. And there's a lot of times where the officers, they just watch. They watch as they say, we watch them do their magic. They just watch the clinician do their job. And then they're like, wow, that was pretty cool. And they leave and everyone is safe and they don't even have to, and then we might make referrals for that individual and set them up with services. So, and we notice too is that we will have family members call the police department asking for the co-response and say, can I have an officer with a clinician here? Here's what's going on, especially somebody with chronic mental illness.
Right.
You'll have a mom or a dad calling and asking for assistance, but it's a huge benefit to the cities and towns that have it. We know it's a benefit. The emergency rooms see it as a benefit because it decreases how many patients are coming into the emergency room. So that's been a big help.
Yeah. And I think, too, you hit the nail on the head when it's not like a classroom scenario where people are like, oh, my God, but when they actually see the behavior being modeled and then they see that it has a great effect, I mean, you're much more likely to copy that behavior.
That's right.
I mean, my gosh.
But talking about the classroom setting, I should so our program was chosen through William James to be part of this certificate where it's a classroom of 6 clinicians and 6 officers throughout the state of Massachusetts. And these are individuals that are already doing this work.
Yep.
And what they're learning is different techniques when they're out on the field. But the benefit, too, is you have officers and clinicians in the same classroom and very different views about examples of things that could happen. But at the end, they come to a decision together of what would be a best case scenario. And they learn different, tactics that they can utilize in the community. And our clinician that's been in it now 3 weeks has come out with, and she was already really good at what she does and does it, she knows it and does it really well. But she's coming out of there learning so much more and just so excited about doing the work with the officers because she's learning a lot. The officers are learning a lot, and it's just growing the program to be even bigger than what it is.
Well, just have that excitement and the awareness and to know you're making a dent in what's such an important topic, has to be a win-win situation for sure. Can you give us some specific examples of situations that you've been really proud of or that, impacted someone to a great extent?
I didn't think you'd ask me this question because now I have to think.
I surprised you.
Yeah, because you have to remember we average around 400 to 500 evaluations a month.
That's just crazy.
It is.
And that's before Fall River, right?
Yeah.
So we'll have to see what our new average is. So we impact a lot of individuals, and it's hard to be really specific about things.
I think one particular case that comes to mind, and it was more of, it wasn't just us, it was us and our youth unit, our youth CCS unit. At the time, it was called the CBAT unit, where they had a particular, without going into great details, but they had a particular child that lived in a residential setting. And every time they got discharged, they were not successful. They kept coming back. And we figured out how to work with that child and really figure out what the residential setting needed, what that child needed, and built a relationship with them when they were with us. And it ended up becoming like a team effort with all of us, that we listened to her and we brought this child back and did like a warm handoff and talked about what works. And then we didn't see her again. And we were seeing this person all the time. But because we sat down and really listened to what they had to say and came up with a really good plan and worked alongside not just the child, but the program that they were in, and actually physically brought them there and said, this is what we've been doing, it was really successful. And we did not, it's been, I think, almost 2 years since we've seen her.
It's like you provided the missing link that just held everything together.
Yeah. So to me, like, I remember that being a case that I really felt like was really successful when it came to teamwork.
Yeah.
It came to teamwork amongst our programs, but also teamwork where including the patient to be part of that team effort of what needs to change in order for them to be successful.
And I think when anyone has a piece of their treatment plan, they own it more. Like they feel like they're part of it. And I think that's important too, and that's what you've established as well.
And I think one of the other things that we started doing about 2 or 3 years ago, and I try to say this lightly because it's, so obviously we're not a shelter in no means, but if we see, one of the populations that we tend to lose are the homeless, right?
Yeah, sure.
When we assess them and we want to connect them to like a detox the next day or a service, and then they walk out the door and they don't have phones and we can't get a hold of them.
Right.
And we know that they came to us and they want to go into treatment. They want detox or they want to go into a partial, whatever the services that they want, like our crisis unit. And then all of a sudden they walk out the door and we don't have a way to get a hold of them. And what we found is that if we know that this person's invested in wanting treatment and they want to follow through, and we know we can get them connected first thing the next morning, we have allowed people to stay with us that night as long as they're safe to be there and connect them into the service the next morning.
That's great.
So that we don't lose them.
So you touched upon detox a little bit. So can you just explain what happens if it's not just purely mental health? What happens if many of their mental health issues are based in addiction? What do you have as far as treatments for that?
So we always, right, it's always tricky to figure out what comes first, right?
Yeah,
Is it the mental health or is it the addiction? And it's the responsibility of the clinician to determine how significant is their substance abuse. And if their substance abuse right now, is the main issue, like you're not even going to be able to touch the mental health until this person detoxes.
Right.
At that point, we might be looking at a straight detox for them and then connecting afterwards. So that's it's all about figuring out how often they're using and what the likelihood is that they're going to go through withdrawals. If it's someone that is using, but they have never gone through withdrawals, they know what it's like, when they stop using, they'll tell us what typically happens.
Right.
We might say, what, this might be a perfect crisis stabilization unit patient to go into our CCS and get the services they need, because they're going to get the mental health aspect of it, but they're also going to get a touch of the substance abuse. And when they're done, they get connected to resources in the community to continue that work going.
Of course. So now, as we close, what would you like to share with our audience as far as that one important message you want to get out there?
I always think the best way to say it is, I think we've said this before, like we see you, we hear you, And I forgot what the third thing is that we normally say, but we want people to know that, our biggest thing when I think the best way to describe it is if we're bringing a clinician on board with our team, we train them to always look at the individual's needs and what is going to stabilize them as best in the community. And that's the model we've had up until we moved into Fall River. And it's still the model we have in Fall River. What we want folks in this area to know is we're not in the business to take their rights away. We're in the business to connect them to a service to make them as successful as possible in the community. And we don't want them to feel intimidated by calling us, because sometimes that phone call might just be a phone call that you talk to a clinician on the phone like, hey, I'm not having a great day today. And that clinician might talk to you for a good 20 minutes and all of a sudden you feel great and you don't even need an assessment. Because we always have clinicians on and they answer the phones. So we just want people to know, if you're hesitating, don't just pick up the phone and call and tell us why you're hesitating and let us walk you through it. Because we definitely want to be a partnership with the client that we service, and we want people to know that their voice does matter when we see them, and we want to know what their needs are, but we're not going to know unless you call us.
And that number one more time?
508-996-3154.
Excellent. Ladies, thank you so much. It was a pleasure having you on and learning about what Fall River has to offer. So in ending, I'd like to thank you for listening to our show. If you'd like to become a sponsor, please contact us at 774-319-4230. Special thanks to Ron Gamache for our intro music and the PC Institute for producing our show. And remember, Bay Coast Bank is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Bye now.